Thank you very much. It's a pleasure to be here today. I really appreciated the prior speakers' presentations, particularly as they pointed out the major complexities in the issue of studying lactation and breast milk. And this is a good segue into maternal health. And my presentation today will focus on the evidence for lasting effects of lactation on metabolic and cardiovascular health outcomes in women. And as you may be aware, this area of research has received relatively little attention until more recently, perhaps with an uptick in the last 2 to 5 years. But the topic has important implications for early prevention of heart disease and diabetes in women during the childbearing years and beyond. This is a really challenging area of research, which I think you can appreciate from a lot of the presentations in the past couple of days. And I'm going to point out the reasons that this particular area in looking at longer-term health outcomes in women are so difficult to study in my talk. But there is emerging evidence from more rigorous studies, which have longitudinal biochemical data, that I hope will provide the impetus for intensified research in this field because of its unique and high relevance to the improving women's future health. So let me start with going back to what we knew from an AHRQ report that was done in 2010. We basically have long-standing evidence of excess risk for women's health of not breastfeeding. And the two diseases that they had sufficient evidence to evaluate were breast cancer and ovarian cancer. And those are fairly well established in the literature as not breastfeeding increases the risk fairly modestly 4% or 27% with ovarian cancer. And there's really, they commented, there's insufficient data to estimate excess risk for type 2 diabetes and cardiovascular disease. Now that has changed, and I'm going to present the new evidence. But cancer research has just moved into the area of genetic markers and looking at differences in risk. And it's a really important area of research, but I don't have time to give you any more info on that today. So what the objectives of my talk are really to look at and describe the evidence basis for lactation and future cardiometabolic disease in women. And those entities are the metabolic syndrome, diabetes, hypertension, and cardiovascular disease. Secondly, I'd like to discuss the importance of antecedent cardiometabolic risk factors to causal inferences in lactation and cardiometabolic disease risk across the childbearing years. And this is the emerging evidence that we need to look at closely. And thirdly, I'd like to identify the contribution of pregnancy-related risk factors, gestational diabetes, hypertensive disorders, as early harbingers of cardiometabolic disease in women, and the major research gaps with regard to these specific conditions. So, as we've heard previously, there's a reproductive continuum of pregnancy and lactation. And there's a conceptual model regarding this in terms of risk of diabetes and cardiovascular disease. Pregnancy and lactation form a single continuum within the reproductive cycle, where alterations in physiologic demands may have lasting consequences for future disease outcomes in women. And the postpartum period may be a critical period for early disease prevention in women, with lactation playing a prominent and unique role within this limited time window to lactate. So as we've heard before, this continuum extends from before, during, and after pregnancy. While we are fully aware that most of the research had in the past and currently is focused on pregnancy and how certain measures during pregnancy may alter pregnancy complications and perinatal outcomes. And understandably, this is an important area of research. But we know much less about the preconception period, where there are very few studies that have looked at maternal metabolic risks, understandably because they're difficult to conduct. And the other critical period of the continuum, the postpartum or postnatal period, where there again are differences in energy and metabolic risk factors and how those relate to future health have rarely been studied. And there are very few longitudinal studies that extend to the postpartum years or several years and decades beyond. So let me just review what the normal metabolic demands are of pregnancy that create a stressful metabolic milieu that affects the fetus. And these are the blood lipid, triglyceride, 200% increase, insulin resistance, which is elevated, accelerated starvations, and you have these very, very highly variable glycemic excursions, and a fat mass deposition, understandably. And the normal part of pregnancy is increased inflammation. And certainly, the cardiovascular adaptations also pose a stress to women. You have a 40 to 50% blood volume increase with red cell mass increasing, but not proportionately, and the heart has to work more, and the cardiac output is increased, but blood pressure declines a little bit, and for vascular resistance so that the placental perfusion can happen. But each of these different adaptations, if they happened in any other physiologic state, would be considered pathologic. A 200% increase in your triglycerides. Pregnancy in its normal functioning is sort of a metabolic syndrome-like state. But what happens is that pre-pregnancy obesity may complicate this scenario and cause women to have greater risk and excess metabolic aberrations. And what happens is we develop complications such as gestational diabetes, which I think you're aware of, and there are different prevalences in that particular complication depending on the testing method, and these are a couple of the ones that are currently used. And then hypertensive disorders of pregnancy. So how the adaptation to pregnancy affects risk and future disease development is extremely important. And in a life course model that's been proposed by Sitar, and I adapted it somewhat, we see the neonatal period as this exposure for women that implicates risk. And if women have normal, healthy pregnancies and start out in a healthy exposure, when they were fetuses, we have sort of a risk of these chronic diseases with age and probably after age 60. But if you have a complicated pregnancy, during pregnancy, you may exceed sort of this dotted line, which is the threshold for metabolic disease. And then you may recede after delivery, but your risk is probably earlier in life and more in midlife for the chronic disease of heart disease and diabetes. So this is a meta-analysis that was published a few years ago and just shows you the very specific tight confidence intervals for increased risk of type 2 diabetes associated with gestational diabetes. And the strongest studies, and the point that I'll be emphasizing, are these studies that were longitudinal and had repeated measures. And you can see very tight confidence intervals with the repeated measures and up to a 7-fold higher risk of conversion to type 2 diabetes. And much of that conversion to type 2 diabetes after GDM happens in the first couple of years after pregnancy. And type 2 diabetes, as you're all aware, is associated with higher risk of cardiovascular disease. So this progression to type 2 diabetes is really an important risk factor, particularly in women, that can predict future early CVD. And this has been studied in women with gestational diabetes. And if they don't develop type 2 diabetes, there is still an elevated risk of cardiovascular disease. And 2 studies that have looked at this prospectively in a longitudinal manner have shown a 30% higher risk of developing cardiovascular disease. They're based on sort of weaker data sources, but they're very large samples, but they have not looked at lactation in this scenario, and they have not collected biochemical data specifically. So biochemically, I think we heard a little bit about how lactation influences the metabolic profile during lactation. You have a reversal of the pregnancy adverse metabolic profile. Lactation more rapidly causes declines in blood triglycerides and LDL cholesterol. It preserves higher HDL cholesterol. And when women are breastfeeding and you measure blood glucose, the fasting levels are lower, as well as the fasting insulin. There's increased need for calories, and there's a modest weight loss, but some women gain weight, and it's variable. So we have some interesting metabolic profile effects, but whether that's mediated by energy utilization and energy and weight loss is still up for question. So how do we do research in this area to address issues about causality? And that's the limitation of most of the evidence in the field, is those studies were unable to address reverse causation issues in the study design. But we really can't do randomization, and the cluster randomized studies are not ideal because they don't have an unexposed group. And if the effects of lactation is really strong, any exposure, even a short or lower exposure, may be blunting the associations. So we also have this prospective epidemiologic evidence that I'm going to go over in a minute and show you what the findings are. But most of those are self-report of disease events and retrospective designs, and they don't have any antecedent biochemical risk factor measurements. And almost none of those studies had any information on pregnancy complications. And as I just showed you, groups with pregnancy complications have a differential risk of diabetes and cardiovascular disease outcome. So it's important to take that into account. By antecedent biochemical risk factors, I mean measuring risk factors prior to the exposure. The exposure in this case is lactation. So almost none of the prior evidence had any biochemical data, and certainly few risk factors prior to lactation, except for probably self-reported BMI in some cases. So these are the studies of odds of hypertension in women associated with lifetime duration of breastfeeding. So you can see the pooled odds ratio is about a 7% reduction in risk of hypertension. And then if you look across the categories by duration, so the any versus never is about a 7% reduction in risk, but across the categories of increasing duration, you see about a 12% reduction in risk of hypertension, but no dose response. So a modest effect. It's a very combined information from very large studies, large number of studies, large sample size, but again, reverse causation issues remain. 5 of the 7 studies were cross-sectional. There were no graded associations, and they certainly didn't look at pregnancy complications or antecedent risk factors. And there were very wide age ranges, with the studies starting in older ages, women. Here's the CVD hospitalization and mortality. You sort of see the same similar association, maybe a slightly stronger protective association with CVD hospitalization and lifetime breastfeeding, but a much stronger association for CVD mortality. Very interesting protective association of breastfeeding. But again, there's no real graded association in any of these studies, or no dose response with increasing lactation duration. And here's a summary of the studies that look at lactation, hypertension, CVD risk factors, chronic heart disease, coronary heart disease, and CVD, a combination. So these studies have a variation in the age of the women that they look at, and you can see there's quite a variation in the relative risk reduction. Most of them look at the relative risk reduction in these CVD outcomes with breastfeeding for 12 months or longer. So if with CVD mortality, again, you see the strongest protective reduction in risk, but that was only found in women under 65. And the EPIC CVD outcomes with incidence of coronary heart disease, 29% reduction in relative risk. And then the Women's Health Initiative Nurses Health Study follow, and these other very large epidemiologic studies also consistently find these protective associations. In the last section of this table, we're more looking at risk factors and different age groups and somewhat younger age groups. And there's a mix of findings here with no significant differences or slightly modest risk reduction. The Danish national cohort has some interesting data, finding a 20 to 30% reduction, and those women at baseline were 30 years of age and followed for about 7 to 12 years. So some interesting data. Again, none of these studies deal with pregnancy complications or biochemical risk factors dealing with metabolic state or risk status for the cardiovascular risk before lactation. This is the EPIC data in its compilation across breastfeeding duration, and you can see there's very wide confidence intervals. These are very difficult events to study because of the sample size number that's required. But again, a tendency for a protective association, but perhaps the relationship with extended breastfeeding or may not be clear, or in a dose-response association. These are the studies, the epidemiologic studies, which are prospective studies that follow women later in life and look at the progression to type 2 diabetes associated with lactation. And the studies these studies universally find fairly weak effects, but they're starting in older women who are median age of 52 or 63 at the baseline for the study. The EPIC study, again, slightly younger women enrolled, found somewhat stronger protective association, but it was not significant. Again, progression to type 2 diabetes, it's incident diabetes, is something that's, again, still, if you don't have a high-risk population such as gestational diabetes, there's a very low rate of progression at some of these younger ages. So it's harder to study and takes a longer term. Most of these were only 7 years to 12 years post-baseline. So the issues with internal validity of these studies are important. There's no antecedent metabolic or CVD risk factors before lactation. There's self-report of the disease outcomes. Women under 45 are not routinely tested for diabetes or CVD, so there's a selection bias in who is detected as far as having diabetes in women of childbearing age. And they're excluding the highest risk group of young women at their baseline, when their baseline follow-up starts so late in life at 50 years or 60 years of age on average. And there's no graded association, so they're fairly weak. And there's unknown pregnancy complications. And some of these are cohort effects because they have very low rates of GDM in older age women. So this is the previous conceptual model that I showed you, and I just want to emphasize what the differences are in the studies that I just summarized, and then introduce a couple new rigorous studies that actually overcome a lot of the limitations that I just outlined for you. So these are the studies that we looked at in general that start following women in mid to late life. So that's 50 and 60, and some of them enroll women at 80 years at baseline. They're well beyond the childbearing years. Childbearing and lactation ended decades ago. So the area of risk that's proximate to these deliveries you see below the threshold, we're missing that group of women. But the Cardia study, which I've been involved with, has women measured with biochemical data preconception. So that's the preconception before pregnancy, what's the metabolic risk? And though that's a mean age of 24 for that cohort. And then the SWIFT study of women with GDM measures the metabolic risk during pregnancy. So that, again, both studies have biochemical objective data and measure risk status extremely well under rigorous research conditions prior to lactation. And then they also have repeated measures of testing for diabetes and cardiovascular risk factors after weaning, post-lactation. So longitudinal biochemical data. And the other feature of these two studies that's crucial is the studies take place across the childbearing years. And in the case of Cardia, it's through the childbearing years and 30 years later, so when women were 54. So the longitudinal measures of the antecedent risk factors are crucial for any causal inferences, because you have to establish that the women who breastfed or did not breastfeed, or differences by duration, had the equivalency of maternal risk status, metabolic risk status before lactation, to address the potential confounding. And that's why we do randomized trials to make risk factors equivalent at baseline. So the studies that I'm going to talk about in a minute, that's basically the intent of how they were designed. They're observational studies, but careful design and analysis plans to deal with potential confounding and reverse causation. The other important feature of these studies is because they're measuring longitudinal, repeated biochemical status, they're able to look at change in the metabolic risk factors and look at persistent effects that may determine the impact of lactation on disease risk. And they also look at pregnancy complications. And this is unexposed group of no lactation is present in both of these studies. So I'm going to talk now about Cardia first, and then the SWIFT study in terms of how lactation has been associated with incidence of diabetes. And I'll refer you for the details to this publication in JAMA, which came out in 2018. It's the 30-year Cardia study. And the study involves a multi-center, it's NHLBI funded, 50% Black women and white women. They were 18 to 38 years of age at baseline, and 4 centers across the U.S. This is a pictorial diagram just showing you examples of Cardia. Each exam is at the top with year 0 through year 30, and each vertical blue bar represents an exam. And women were not pregnant when they came to our exam, so we're tracking pregnancies between the exams, and some are non-GDM, completely normal, and others are GDM. And this is just the progression across time that will give you an illustration of the time-varying complex modeling analytic approach that's involved in these studies. But every exam has blood pressure, all of these risk factors. This is our publication in Diabetes 2010 from Cardia, and shows the strong inverse association with increasing lactation duration and the incidence of the metabolic syndrome in women. And you can see that the orange bars are women with GDM births, which have a much higher incidence of the metabolic syndrome, but the same inverse association is found for non-GDM women. And then finally, at lactation greater than 9 months, the risk of the metabolic syndrome is equivalent for the GDM and the non-GDM. This is our 30-year follow-up study characteristics for the women in Cardia across lactation duration categories. And the reason I'm illustrating this is because I want to show you that there are slight differences in the baseline characteristics. There are more overweight women starting out in the non-breastfeeding group, Insulin resistance is slightly higher in the shorter duration of breastfeeding and the no breastfeeding group, but I can tell you those are clinically very similar measures of insulin resistance. There are not extremes. These are healthy women at baseline. And history of GDM was not different among the lactating groups. And there are other characteristics that were very similar, such as menopausal status, but the diet did differ. And this is, again, a diagram of the incidence rates of diabetes in the Cardia women over this 30-year period. And you can see the same pattern of strong inverse association from going from no lactation to greater than 12 months. And the GDM subsample is at much higher risk, but the decreasing risk is similar. And our modeling of this, which I'll show you for Cardia, has this strong inverse association that's a graded association that is controlled for fasting glucose, insulin resistance, family history of diabetes, physical activity, diet quality, perinatal outcomes, and even follow-up change in weight. And it persists despite control for all of these antecedent and follow-up factors that have been associated with diabetes as well as potentially lactation. So I just want to go over SWIFT quickly. And I think I have a few more minutes because we had a little bit of a late start. But in Annals of Internal Medicine, this is our cohort called SWIFT. That is a cohort of gestational diabetes women who were followed from pregnancy through and then enrolled in a OGTT and other assessment visits at 6 to 9 weeks postpartum, and then followed annually for these metabolic assessments. So this is the longitudinal observational design, just to show you when we recruited them, and there are objective antecedent measurements of metabolic status during pregnancy. They're followed up at annual research visits from baseline through 2 years postpartum, and then we have a 10-year visit planned, and they're rigorous OGTTs and biochemical measurements, and also diagnostic health records. So our study baseline is 1,035 women with GDM deliveries from 2008 to 2011. They're all followed from early postpartum, 1,010 women. And the annual follow-up showed very high retention of 959 women, had OGTTs or EMR laboratory data, and we had a 12% incidence at 2 years postpartum, and almost 20% converted to incident diabetes at 8 years. And again, you see exclusive formula feeding to exclusive lactation breastfeeding, and you see a strong inverse association with incident diabetes among women with GDM. And these are the actual counts of the sample size in each group, which are sufficient and had excellent follow-up duration and retention. And importantly, we can see that the major antecedent risk factor, which is the 3-hour OGTT, which is our metabolic indice, did not differ by lactation intensity at 6 to 9 weeks postpartum. This is crucial, that there is not a difference in the metabolic state. The severity of GDM was similar. That was true for also GDM treatment, which is right below. There wasn't differences in who needed oral meds or insulin. So it's saying that there is a similar metabolic state in who was able to breastfeed at these different levels, and it's not a reverse causation from some metabolic aberration changing what women are able to do with breastfeeding. So let me go on to the models here, which is basically showing a strong 50% reduction in the risk of incident diabetes, very similar to what we found in Cardia. And this is with lactation duration starting at greater than 2 to 5 months, and it's continuing. And then we adjust for multiple risk factors, intervening risk factors, and the weight change being one, and it was not an association that was mediated by differences in weight loss. So something metabolically with lactation. So there's better early postpartum glucose tolerance. It's a strong graded inverse association for 2 years and 30-year incidence of diabetes in women with GDM and without GDM. And it persists after counting for these antecedent risk factors and psychosocial risk factors and sociodemographic risk factors and behaviors. And this information extends from before, during, and after pregnancy. And our mechanistic model is open for question and discussion. We really don't know the mechanisms, and that's an area for future study because there may be effects of prolactin on the pancreatic beta cells and differences in weight loss or visceral fat, but there are open questions about what might be driving this. And in terms of the effect and why it's important to look at lactation and risk of diabetes is because the Diabetes Lifestyle Prevention Program found that weight loss of about 5 kilos with physical activity and diet had a 50% lower risk of incident diabetes in impaired glucose-tolerant adults. But lactation is having a similar impact, and it does not seem to depend on weight change because they were very similar. So again, this is a specific lifestyle behavior in a critical period, the postpartum period, that may actually have very strong metabolic consequences. And just to conclude that there are annual excess deaths attributable to suboptimal breastfeeding, and 78% are maternal and related to either myocardial infarction, breast cancer, and diabetes. And I think this gets at the point that heart disease is the leading cause of death in U.S. women, and that diabetes is also implicated in that process, and breastfeeding has a larger impact on women's health than was previously appreciated. So I'm going to end there, and thank you very much for your attention.